Good morning, everyone. We're going to start the next session, so please have your seats. And we're going to ask the speakers to also be ready. First speaker is Dr. Abreau. He's an associate professor from USC, and we are delighted to have him to talk about salvage options after FT failure.
Good morning. Good morning, everyone. Let's please take your seats. And again, thank you. It's my last talk. I would like to thank the organizers, thank Jack, and really putting together a very nice program. Thank you. So the topic that was assigned to me is repeat focal therapy for prostate cancer. And some definitions or endpoints of focal therapy. Some people may use PSA, some people may use imaging, MRI or ultrasound as an endpoint. Some use biopsy, clinically significant cancer on repeat biopsy or not. Some may use retreatment as endpoint, but most would agree that maybe freedom from radical treatment would be a good endpoint for focal therapy overall. Metastasis, systemic therapy, prostate cancer mortality, and so on and so forth. And then there is now this definition of failure, which is like a composed definition of any of these parameters that are there, including repeat treatment. And repeat treatment that they take as failure, they say if you do more than 3 times, that would be a failure. So just some comments on these definitions that are out there. For example, this manuscript from UK, in 1,400 patients, they actually repeat HIFU in 10% of their patients. So just keep in mind that when you do focal therapy, tell the patient that there is a chance that you have the recurrence and you need treatment, probably 10% or 15%, and depends on your series, but it's something that is common. Recurrence after the primary recurrence could be infield, could be out of field, or could be both. And these have implications, not only in prognosis, but how you treat your you go to retreat. And I will go through this in details. I put this together with our group, and I'll go one by one with you. The first one is infield recurrence and I can't read it, and persistent prostate cancer. So what happens there is it could be improper treatment, you didn't deliver the treatment appropriately, or there is heat sink, there is some technical issue that there is a cancer persistency, right? Or the cancer could be resistant or resilient as well. So this is what happens if you have infield recurrence. It could be also on the margins. And for the margins, the same thing applies. There is some technical issue. However, it could be also a failure of planning the treatment. MRI margins, how you select the margins, how you do mapping, and then you may have cancer at the margins. And the last one could be a de novo. You treated all the fingers appropriately, and for several years it's fine, and then the cancer comes back. This could be a different cancer. This is probably the natural history of prostate cancer. Now, going for out-of-field recurrence. Out-of-field recurrence, the first one is de novo. Again, you treat it appropriately, and then the cancer comes back in the contralateral side, one area that was not treated. This is probably aging process, or again, field defect or prostate cancer natural history. This could be also cancer progression. We know that there is a disease. We knew from the get-go this could be a Gleason 6, it could be a Gleason 7, and this cancer could progress, upgrading or upstaging. Again, a natural history of prostate cancer. There is one that particular is interested to me is when there is cancer there that we don't identify. And this is what we call selection failure by imaging, by biopsy, by markers, by whatever, you name it. This could be because of the multifocality of the prostate cancer. But I always question how we do mapping biopsy, target biopsy, MRI, markers, PET-CT, ultrasound, multi-parametric ultrasound, you name it, and we don't find this cancer. And then 6 months later, the cancer is there. How is that possible? Well, we miss things, but this is too much. So I was thinking about this, and I bring this here to the colleagues. Maybe you can discuss this. And I found this concomitant tumor resistance is a concept. So what happened is prostate cancer is multifocal. Then there is an index lesion, and this is the secondary lesion. Then you go ahead and you treat the index lesion. When you treat the index lesion, the secondary lesion may grow, because the index lesion was actually suppressing the other foci. And in fact, when we go to the breast cancer, there is some concept on this. There is some clinical as well. I just brought this basic science manuscript. There are 2 foci of cancer. One is larger than the other. The larger grows and suppress the smaller. When you do surgery, you remove the larger, the smaller grows. So this could happen with prostate cancer as well. In fact, there is this manuscript showing that exactly this. So all these rats, they had small cancer, all of them. The first one in orange, they implanted another large cancer. The second was a mid cancer, mid-size. The other one, the blue, was a small cancer. And the Shen, the non-treated, they had only the original cancer, okay? So larger, mid, small, and no cancer at all. Know that all of them had one smaller cancer from the get-go. And look what happens. The cancer that is, the cancer that is smaller still keep growing. But the larger cancer suppress the smaller cancer. So the smaller cancer doesn't grow. This is prostate cancer. So I'm thinking, just bringing this up to the group, maybe we can develop something to investigate this further, or maybe if there is less, please tell me. Okay, keep going. Prostate cancer recurrence now clinically. When the cancer comes back after focal therapy, you have all these options: surveillance, radioablation, prostatectomy, radiation, systemic treatment. And I want to spend some time on this slide. One, patients. Patients' preference, come back to the table again. If they are willing to undergo another treatment, they may now come with all these trade-offs. Quality of life, the trade-off of cancer versus quality of life, comorbidity, start performance, life expectancy, so on and so forth. So these are all parameters that should be taken into consideration. There is a prostate now, but this prostate now is different. There is distortion, there is calcification, the urethra is not in place anymore, the rectum is pushing up. So there are a lot of things to take into consideration when you go ahead to do a repeat treatment. And of course, there are the oncological outcomes. The oncological features, PSA, the grade of the tumor, all these parameters should be taken into consideration when you go ahead and do retreatment. Similar exercise you do from the beginning, you should do when there is a recurrence. And one that I would like to emphasize is the surgeon and institution expertise. Do what you feel you are good with. Select an energy modality and do that. After that, you may do other energies, other techniques. So surgeon and institutional expertise, I think that matters. Some literature review on this topic. We reviewed the literature from up to 2024, and we found only 40 studies on redo focal therapy. So we need to build more data on this. And these studies are summarized here. This is a busy, I'll not go through the table overall, just for your reference. And I will show some of these manuscripts that are there. One thing, there's oncological outcomes and functional outcomes. And going to the literature again, all studies are retrospective, short follow-up, small sample size. The definitions are kind of mixed, so it's difficult for us to come out with a nice review of the literature, but that's what we have. We need to do more. Anyways, this manuscript with 26 patients who underwent HIFU in cryo, and at 3 months, all the patients were continent. There were no complications. And at 2 years, this is important. At 2 years of follow-up, infield recurrence patients have worse prognosis. Okay, so this is something to consider. If your patient had infield recurrence, they may do worse. And this was also shown, similar group, but this is more a multi-institutional study, and showing the same thing. If the cancer recurs within the infield, they may have worse prognosis. So keep in mind, this may change your approach when you're treating these patients. Another manuscript with only 12 patients who underwent cryo and salvage and repeat cryo. Continency was low. I don't know why that happens with them. And oncologic control was also suboptimal, to be optimistic. So I don't know exactly, but it's a small number of patients that's there. This one is 25 patients who underwent salvage HIFU, and oncological outcomes are acceptable, no complications, and functional outcomes are quite good. So overall, what I see is like functional outcomes is still kept appropriately, complications are low, oncological outcomes are mixed. This is the largest series that I could find. This is 65 patients who underwent HIFU and repeat HIFU. And interesting that, again, their functional outcomes, after the second HIFU, 30% of the patients are impotent, and continency is kept for most of them. And there is very low complications, similar as for the primary setting. So it's still safe, it's still very good functional outcome. Oncological outcomes is all over the places. And I just want to show this one. It's a large series that they did whole gland HIFU and repeat HIFU. And very important, none of them had fistula. I think this is quite reassuring. If we come to our patients and say, hey, if you need a retreatment, you should not have fistula. So redo ablation, if it's out of field, if I can show some, if I can recommend something out of this literature review, if it's out of field, then it's pretty much as a naive prostate. It's straightforward, you can do any treatment there, we should be fine. Infield recurrence, think about, these patients may have worse prognosis, so you may consider radical treatment. Multiple lesions and so on and so forth, then it's similar as a primary setting. You may go ahead and do prostatectomy or radiation therapy. If there's a shorter time from recurrence, if you did appropriate treatment, then this might be an aggressive cancer. You may do prostatectomy. If you don't feel that actually you did a good treatment, then you can go ahead and try again. The data supports this. And longer time, you may go ahead and redo ablation. So I don't know how much time I have. If I'm up, 3 minutes. So I will just show some cases, and when time's up, then you cut me. That I just show some cases that I did just to exemplify what I said. So this is a patient that came to me with a Gleason 7 prostate cancer, and with a large lesion on MRI, Paredes 4, and I did cryoablation on him anteriorly, and he did well for some time, but then he came back with recurrency just next to the cancer on the right side. I don't know if this was there before or it grew, but anyways, it was there. So in this case, it's pretty much straightforward. Again, as I did ablation for the right side, I just repeat ablation to the other side. But then this time I was more, I cover larger area because one of the cores on the transition zone was showing lesion 4+4, very tiny little focus of 4+4. So this patient is actually fine now. His MRI is completely negative. PSA is 0.7. He had a meatus hysteria that I just dilated, and he is doing fine now. This is somehow more interesting case. This patient had a radiation therapy, and he came to me with recurrent prostate cancer. You can see the lesion there on MRI. And all the metastatic workup was negative, and I did cryoablation on him for this anterior lesion, as you can see there. On follow-up, he was doing fine, but then afterwards, PSA started rising a little bit. There was another PET-CT that showed some SUV uptake, MRI with small lesion there. Maybe I left this behind. Potentially, that was my fault. I mean, technical fault. I don't know. It's difficult to say. It's right at the edge, but could be. And I went ahead and repeat ablation on this patient. And for this, and I cover a larger area at this time. So this is salvage cryoablation after radiation and repeat cryoablation. So these are all possible, right? As soon as you save. Main concern I had with this patient was actually not rectal fistula, but pubic osteitis, because it was radiated, then one ablation, and then another ablation on top of this. Be careful, because the posterior part we can see with the ice ball. The anterior part we don't. The anterior part we plane. We say it will be 1 centimeter from the needle or 1.5 centimeter from the needle, and should be, but you know, things can go wrong. And afterwards, he was actually doing fine. He had no complication. This is his last MRI and his last contrast enhanced ultrasound, and just 2 examples to show what we discussed. Thank you.
Thank you.
Thank you. Any questions from the floor? Maybe I just have 2 questions. First of all, with your experience and suggestion that sometimes new tumors may appear because we have actually destroyed the first one, would that have some implication on your margin? Because initially probably we're just thinking about quadrant around the tumor, but if it's not near any functional important structure, in fact, should we take the first opportunity to get a bigger margin in order to prevent what you have suggested that may happen? And the second follow-up question is, if it is recurrence within the initial lesion, then do you think it would make sense to choose another modality to make it happen?
That's a very good point, the different modality. This is a very good point of a different modality. And I say this a lot to the patients who choose radiation therapy up front, that they come for salvage, and I say, hey, you repeat radiation therapy. The cancer was resistant to radiation therapy. I think it's a little bit different than this energy modality that we use, because all of these modalities that we use is kind of all or nothing, right? It's not like something that may stay there. If it stays there, it's because you didn't treat it in the margin that I showed. So in this case, I go by energy modality by location of the cancer. And I wouldn't change the modality based on if there is recurrence. It's more based on the location of the cancer.
I see. Thank you.
Thank you.
So, yep, very close.
I was very interested in the data you showed on the interaction between multifocal cancers. And, you know, one of the phenomena that I don't think we've paid enough attention to in this area of local failure is the injury response. So in other words, you treat a cancer and there's some tumor cells that you don't know about at the margin of the treatment zone, and you have this whole cascade of injury response with release of cytokines and growth factors. And there's a number of models where, the ones I know about are in lung cancer, where the injury response induces a more aggressive phenotype in the cancer. And I just wonder if it's kind of along the same lines of what you're talking about, whether you think there's any evidence that this is a reality. We know that these cases, I mean, you did point out that the infield recurrences tend to behave worse. So is that because we're making them worse by inducing this injury response and therefore kind of aggravating their molecular phenotype?
I'm happy you talking about, because my idea with this to bring to the group was actually to initiate. I'd never seen anybody talking about this in the focal therapy. So that's why I brought it up, for us to start this discussion and see if there is anything we can do to modify the disease. It's clearly to me that whatever you use, you will have 15-20% of recurrence. Doesn't matter how energy you use. So we need to modify the disease somehow to get rid of additional 10-15% and have 5% left. There are two things, Dr. Klotz. One is some patients actually, it works as a vaccination, right? Actually, they have a better response with cryo, with IRE, that still proteins that it's like vaccine effect. And some of them may not respond well. I would love to answer your question. I will further dive into this and investigate and keep it, this ongoing. But that's exactly what I wanted to bring.
It wouldn't be that difficult to look at gene expression in the failures compared to the baseline, and or kind of genomic alterations, just to see whether there is a real change in the kind of tumor that it is pre and post treatment.
Sounds good.
I don't think anyone's done that yet.
Thank you.
Well, thank you for the discussion. Now, may I introduce Professor Lepor to the podium. Professor Lepor has been with NYU. He's now practicing in New York with vast experience in urology. And the topic that he is going to share with us is prostatectomy after focal therapy. Thank you, Professor Lepor.
So thank you. So if you really look at what we're trying to accomplish, right, we just don't want them to die of prostate cancer. We don't want them to get metastases, and we want to be mindful of their quality of life. So I think that's ultimately what our goal is in treating prostate cancer is balancing the risk of the disease. And we learned from the Scandinavian trial that many of these patients, if untreated, would do fine. But there is a benefit to treatment, and hopefully we can achieve that benefit in many cases with focal therapy and reducing issues related to quality of life. So again, we showed this data, and this is looking at our outcomes, and this is looking at our freedom from really any clinically significant recurrence. And again, and we talked about this earlier, just because you have one microfocus of pattern 4, that I do call clinically significant recurrence, but that's sort of by definition, but in many cases that may not require intervention. And this is looking at the infield 5-year disease recurrence, and it's about 14%. And this is looking at out of field. And as we get further from treatment, our out of field and infield disease recurrences are beginning to merge. And there's an interesting concept, which is freedom from failure, which really makes no sense, right? Because all these patients that I'm showing you have intermediate risk disease. They all would have been going on to radical prostatectomy or radiation therapy. So why is it a failure if they ultimately end up getting the treatment that they would have had initially, right? But this is just the definition that we have, is that if you have a radical prostatectomy or you develop metastases or you die of the disease, then that's failure. But be mindful, these are all intermediate risk disease who the guidelines pretty much say would be treated. So I always like to come to a meeting where I can give you my own data. I would have loved to talk about oncologic surveillance, the discussions on MRI and PSA and sort of the role of these modalities. But I was given the topic of salvage treatment, and I'm happy to announce to this group, I'm not very experienced with salvage treatment because our patients really do quite well after focal therapy. So I always like to learn something, Jack. So initially I did tell you, Jack, you're giving me something I can't really bring my own data to. And the next day I said, okay, all right, I'll give the talk. So this is the group who had salvage management. Again, not every patient who had a clinically significant cancer went on to salvage treatment. And in fact, we only had 12. About half of those had radical, the other radiation, and the majority ended up having a focal salvage ablation. We had 6 that went on to active surveillance, and in all of those patients, they had 1 core or less of Gleason grade group 2. So because of that lack of experience with this topic, right, which I'm happy to tell you I don't have, I had to go through the literature. And often when you go through focal therapy, the literature doesn't really help you very much because of the poor quality of the literature. So this was salvage robotic laparoscopic surgery. And the most part, this is good. I may need to get new glasses. But in terms of most of these patients at baseline had intermediate risk disease, and at least in this series, intraoperative complications never occurred. And really, if you looked at the postoperative complications, they're pretty insignificant. And if you looked at the oncologic outcomes, only 13% of patients had a positive surgical margin. If you look at biochemical free recurrence, though, it was 64%. So there's a fair amount of biochemical recurrence despite a negative margin, which makes me worry a little bit about the salvage treatment, right? And if you had infield recurrence or seminal vesicle invasion, then you did more poorly. And you know what, I must say, from the few patients that we've had the infield recurrence, if I actually at 6 months see that gland, that lesion has been ablated, and 2 years later you come in and there's a significant lesion, what that's telling me is that this is probably a bad actor. And that's what I think the infield, I'm not so sure it's genetic modification of the disease. I think it just may reflect a rapidly proliferating cancer, but that certainly remains a possibility. Now, you know, we've published that if a patient uses 1 pad a day, they call themselves continent. So I think that's a legitimate definition to say no pads or 1 pad is continent, but you must tell the patient there's a difference between perfect and continent. And the overwhelming majority of these men gained their continence at 1 year by this definition. And sexual function was pretty difficult to ascertain because the majority of men had sexual dysfunction pre-treatment, and you sort of wonder, well, I thought that's the whole reason we did focal therapy was to preserve sexual function. So it's a little bit hard for me to reconcile. So here's another study of 32 patients, and again, these were done robotically. And the majority of these patients, their baseline were intermediate risk disease, and this is a whole spectrum of different ablative energy sources. And again, the thing that's a little bit disconcerting is in this group, you had over half of the patients that had extracapsular extension. That this is only 2 years, right? So this is pretty disconcerting. And biochemical recurrence was 21%. And about a third of these patients after the salvage radical had a salvage radiation. Now, the functional outcomes, again, they're doing quite well from continence. And I'll tell you, I read this paper twice. I couldn't make any sense out of their function, about their sexual outcomes. I did it with a glass of wine. I did it without a glass of wine, and I still couldn't make any sense out of it. And this is a systematic review. And this was recently published. And again, the whole spectrum of energy sources that were used. And again, it's the modern era, so most of these were done robotically. And most of these patients appropriately had intermediate risk disease to begin with. And positive margins were 26%. That's not that out of the range of intermediate risk disease following a radical. And again, what's a little bit disconcerting is this is early on. Now, again, I always go back to the Gleason Gray Group 1 validation. We think that after radical prostatectomy, we cure everybody, right? That ain't the case. I mean, if you look at Gleason Gray Group 2 on biopsy, within 8 years, 25% of men develop a recurrence. It's about 45% for grade group 3. So even after, for primary radical, we certainly have limitations. Now, in this series, unlike the first one I showed, there were a fair amount of significant intraoperative complications. And here, again, continence was pad-free. That's why you got a little, the other study was 0 to 1 pads. But it's a little bit disconcerting at 68% at 1 year. And preservation of potency in men who were potent pre-op was only about a third. So remember how I told you I just can't stand doing those Delphi consensus statements because it's just sheer exhaustion. But here, this consensus panel is made up of the 4 people in our group who do focal therapy and radical prostatectomy, and Penn is one of those, and Samir and Jim is the other. So I didn't give them 80 questions and tell them it takes 20 minutes and it takes 2 hours. And then 1 week later, I asked them again, and I asked them again, and they have to fill it out because I'm the boss, right? But just out of sheer exhaustion. So we ended up with a very limited number of questions, right? And so we did have consensus in our department. And so is the dissection more challenging than primary? Everybody agreed that it is. Does the site of ablation impact the challenges? And we all agreed. I will tell you, if you have an apical tumor that you ablated, this is a challenging operation. And I'll tell you the other thing is if you did ablation on a small gland, you're going to wish you weren't doing. You're going to wish you had a direct line to your radiation oncologist, right? Does the energy source impact the challenge of the dissection? We could not find consensus amongst our group, and I didn't keep asking them until I got a consensus. Are there more technical complications in terms of intraoperative complications? The answer was no. Is urinary continence more problematic? The answer was no. And is sexual dysfunction a greater problem with salvage? And the consensus was yes. So we had a pretty good consensus amongst our group. So in summary, Mr. Chairman, the complications in urinary continence following salvage radical prostatectomy, I think it's fair to say, is on par with that of a primary treatment. Sexual dysfunction, I think, is a greater problem. That there's no comparison between energy sources. There's no comparison between the number of focal therapies. And what I will tell a patient is, and typically the patient that I subject, that I end up doing whole gland, whether radiation or radical, it's the person who has an apical recurrence. Because if they have an in or out of field recurrence that is mid-base, then the same reason I felt it was reasonable to do the first one, we'll do the second. But I'll tell the patient, if you go on and do your second focal therapy, I will never come back and do your radical. That the rate of disease recurrence, I think, is higher. And I wonder if that's the disease or that may just represent the technical challenges of leaving positive margins. The increased rates of disease progression is worrisome. And again, the whole issue of infield recurrences, it may be more aggressive disease. We talked about the genetic alteration. And I do believe there is greater better fire. So the moral of the story is select your patients well, do your focal therapy as an oncologic surgeon, and then when you're asked to give this talk, you won't have much to talk about. Thank you.
Questions from the audience? We're going to move along. Dr. Jeffrey Tuan is the next speaker. He's the head of the radiation oncology group here at National Cancer Center in Singapore. He also holds a clinical program, oncology academic clinical program, basically clinical assistant professor at Duke University, and he's going to talk about radiation therapy after focal therapy failure.
Right. Thank you for the invitation, Jack, for asking me to share this talk. I think the previous speakers have gone through some of the important points, and in the next 15 minutes, I just want to share a little bit of our experience giving radiation after focal therapy. So this is what I aim to cover. I start with the case study, and then a little bit about the treatment options, which has been discussed by the first speaker, and then what about focal treatment after whole gland radiation, as opposed to focal first, followed by whole gland treatment. Some examples. So the first one I'll share is a case that actually I have with Professor Cheng, actually. So this was a gentleman, actually, was initially he was 68, and he was eventually seen by ourselves in 2016. He has the usual medical problems of ischemic heart disease, and has also a pacemaker for bradycardia. Initially, his diagnosis was that of a Gleason 3+3 prostate cancer. I know in these days, these patients are usually offered surveillance, and he was offered that for many years. Eventually, he opted for some local treatment. He had, at that time, HIFU in 2010, and subsequently, he was found to have persistent disease on repeat biopsies. And he was biopsied multiple times in 2009, 11, and 12, and he came back as a recurrent disease of Gleason 7, so 3+3 for most of the course. And he was then subsequently referred to us for an opinion on radiation and was seen in 2016. So we did the imaging, and MRI was done in 2017, and that showed actually a recurrence. There was prior treatment HIFU to the right lobe, and there is a lesion there measuring about 1 centimeter in size. There are also satellite lesions in the apex as well as on the left anterior peripheral zone, a couple of smaller ones. Fortunately, the capsules is intact, and the semivesicles were not involved, and there were no lymph nodes that was detected. He had some issues with urinary retention and had a TRP done, and again, his PSA continued to rise. We monitored him and counseled him for radiation, but he was a bit concerned, and he opted for repeat surveillance scans. So the MRI was done in, again, 2022. And again, that shows that there were some progressions and some new lesions. And eventually, because of the rise in the PSA, he finally decided to proceed with radiation. And we delivered 60 grays in 20 fractions to the prostate alone, given that it was still localized, low to intermediate risk prostate cancer, and no hormonal deprivation was given in this case. So these are some of the pictures on the MRI, showing clearly where the new lesions are on both sides of the prostate gland, and these are the division-weighted images as well. These are the ones that are close to the apex. So this is a typical radiation plan. So we're able to actually give quite good doses to the whole gland and respect the radiation doses to the rectum. This was prior to the use of rectal spacing. So what is the progress? The patient actually had NMR post-radiation, and it showed good response. The lesions appeared smaller, and more importantly, the PSA also came down. We monitored his toxicities during the treatment itself. We see him weekly during our radiation course of treatment, and I'm happy to report that he had mostly grade 1 and 2 toxicities, primarily due to rectal bleeding, but he had issues with hemorrhoids as well. This is an example of the PSA response. So after treatment, PSA came down quite nicely. Also important to remember, without the use of androgen deprivation. So this is a picture of what the initial trend of the PSA was, or the initial HIFU. I think there was some prostatitis or inflammation, and therefore there is a little bit of upwards, downwards, but eventually it did come down quite nicely to less than 2. Upon follow-up, I saw the patient recently in last year. He had some issues in terms of urinary pain as well as bleeding, particularly frequency of up to 20 times. At the time, he was found to have urinary tract infection and was treated appropriately, and the symptoms fortunately all settled quite nicely. Upon last review this year, again, the PSA now remains very low at 0.75. All toxicities has resolved completely. So second case, again, quite similar. So again, he was initially treated in 2010 with a Gleason 6. Subsequently, PSA rose and came to us again for radiation treatment. In this case, we treated him with a long course of treatment over 37 fractions. And again, an example of what the plan looks like. In this case, we gave 2 phases. So the first phase will incorporate both the prostate as the seminal vesicles, whereas the second phase cones down to the prostate. We're very mindful of the dose to the rectum, and again, it was before the era of spacer or rectal spacing. Again, fortunately, there was good response. PSK came down very nicely, and again, unfortunately, he was lost to follow-up. So I think based on our records, last seen in 2019 with a low PSA of 0.45. So again, this is an example of his progress. And case number 3 is one more recently, and I just want to share that in this case, he had cryotherapy with Dr. Jack, and again, he had Gleason 7, and he, upon rebiopsies, I think there was still persistent disease and was referred for salvage radiation. Now we have proton beam therapy available in Singapore, and he decided to go for proton beam in his case. The difference for him is that we managed to put a rectal spacer, so that allows us to actually respect and further reduce the dose to the rectum. And I'm happy to report again, initial treatment response has been quite good, and PSA has came down from a high of 7.7 to 2.0. He just completed his proton beam in 2023, I think last year in August, and he had no toxicities during treatment itself, especially the no rectal issues at all. So just to go on about what is the definition of recurrence after radiation, after focal therapy. This was discussed in the first speaker. So if the patient, this could be in a previously treated area or newly identified foci in untreated segments of the prostate. And because focal therapy usually mandates more intensive surveillance with both imaging as well as biopsies, this tends to happen a little bit more frequent than whole gland treatment. This article I found basically goes through the management of recurrent disease after focal therapy, and some of the things have already been discussed. So focal therapy patients actually are concerned about toxicities, and this has to be discussed with the patient. Most of them, they are offered the same treatment options as they had at the initial diagnosis, and these could include surveillance, radical surgery, and radiation. And again, it's very important to respect that these patients want to avoid jeopardizing the quality of life. This is what they have suggested, to use a risk stratified approach to guide discussion with the patients. So I just want to focus on in the high risk prostate cancer, which are the ones that we tend to see. The discussions will entail a radical treatment with either surgery or radiation therapy. So I think I won't go through this because the first speaker has said, so surveillance is certainly impossible for low volume disease or low grade disease. And we have to be clear about how we define local therapies. So it could be either due on a new MRI lesion or rising PSA. Additional or focal therapy may be requested by the patients, especially if they're very satisfied with the initial treatment. And the retreatment is usually done with either cryotherapy or HIFU. New disease may benefit for additional ablation because these have not been treated before. And again, salvage therapies are usually quite well tolerated. If you repeat them multiple times, 1 or 2 times, then of course they will have increased risk of worsening toxicities. And first speaker also said that failure rates can be as high as about 26% in some series. And gradual decline in quality of life usually occurs with increased treatment causes, repeated causes. And if you do them too often, then you will preclude them to salvage prostatectomy due to the adhesions, especially if the disease is in the apex. So if they are developed into high-risk prostate cancer, then possibly they will then come to us for consideration for radiation therapy. Because often the patients are also concerned about the toxicities of prostatectomy, as it may be more challenging, but most series actually show that it is actually safe and provides good functional outcome in expert hands. In recurrence in the previously treated field may have actually worse outcomes, and possibly the use of surgery may avoid the need for androgen deprivation, which is often combined with radiation therapy in many other centers. So what are the considerations for radiation? Currently now we have improved imaging modalities such as MRI and PSMA PET that allows us to localize the lesions better. There could be a discussion with some patients who are refusing biopsies to confirm a local recurrence. What is the role of androgen deprivation, especially in the high-risk, high-grade versus intermediate-risk cancers, as again, these patients are keen to avoid unnecessary toxicities. What about giving radiation to the prostate or to the pelvic lymph nodes? I think yesterday there was a question asked about whether or not the need for treating or addressing the lymph nodes. Currently now, if we can re-stratify these patients and with good imaging, I think that we are able to pick out those that will be unlikely to recur in the pelvis and therefore offer just radiation treatment or local therapies to the prostate. What about how do we give the radiation? It could be whole gland versus focal. We will be looking at the disease-free interval, how long has been since the initial treatment, and also possibly the longer that is, then we can assume that there could be some recovery of normal tissue function. Techniques in radiation can be used include SBRT, proton therapy, or even brachytherapy. And now with the use of spacer and fiducials that allows us to increase the accuracy and precision of radiation treatment as well as push away the rectum from the high dose areas. And also sometimes with the use of rectal balloons that allows us to fix the prostate a little bit better too. So next I just want to touch about, it is possible to also consider focal radiation treatment for local recurrent prostate cancer after primary radiation. And what, looking through the literature, there is some data looking at it, and they offer good response, but they often come at the price of toxicities. So grade 2 toxicities ranges from about 5 to 18% in some of the series published. And currently in the National Cancer Center itself, we have treated focal SBRT for up to 5 patients. One of them actually we tried to use focal brachytherapy, but was unsuccessful because of slippage of the catheters. And the rest of the patients, we managed to deliver SBRT successfully with a minimal toxicity as well as a good PSA response. All of these patients did not have androgen deprivation, so the PSA is a true indicator of response after radiation. However, we need more time to follow up these patients to look at long-term toxicities. 1 or 2 patients actually had a persistent PSA rise, but at a slower rate. And possibly this could mean that there could be metastatic disease either in the lymph nodes or elsewhere, but they weren't picked up on PET scans or MRI. Again, the use of rectal spacer will allow us to reduce the dose of the rectum and avoid rectal toxicities in this group of patients. Some examples of what it looks like using our SBRT, where we give 35 grays in 5 fractions together with a spacer and gold seeds. So I come to the end of my talk, and I hope that this gives you a glimpse of what radiation can offer after focal therapy. And I'm happy to join in some questions and answers and a discussion on how best to manage these patients. Thank you.
Yes, Jack?
I have 2 questions for Dr. Lepor and one for Jeff. Thanks, Dr. Lepor, for tackling a very difficult topic. I think you really scoured the literature for that one. But I think what we're hearing from you and Andre and Jeff is that these are recurrent tumors. So in some ways, they are bad actors. In some ways, of course, it comes from selection as well, and whether we did an oncologic ablation from the get-go. So you also showed some data, and I think Andre showed some data on getting some T3 cancers as recurrence after focal. So if, based on your reading and the experience and the consensus you guys have at NYU, if you had to go back in for a prostatectomy, would you modify your node dissection template, for example? Would you be doing a more complete node dissection, more extended, because taking in the same principles of being an oncologic surgeon? And my other question for Jeff is, would you tweak your dose of radiation after focal? Would you be worried about giving your normal full dose to give the patient a full treatment? Well, I'm asking these because, we promise patients that, hey, you have small disease, do focal, you're going to have great outcomes. Even if you're in a percentage that don't, we can salvage you. So I think it's part of holding up to that promise and being able to deliver them that adequate care. Thanks.
So, Jack, that's a great question. And I'll confess, I hate doing the lymphadenectomy, right, as part of the radical. And the jury's out about extended lymphadenectomy in the standard primary treatment. So, look, I think that I think it's one thing to have the local failure. I would not modify my approach to lymphadenectomy for primary versus salvage, right? I think that again, because we have a very our oncologic surveillance is really pretty intense, right? And we know we have local recurrences, and we know we have positive margins after a standard radical, where I will really modify my radical as opposed to lymphadenectomy. I would really take a wide margin, as wide as I can, on the side of the lesion. And the one thing I'm concerned about, because the patient that I typically will do the radical on is someone that has apical recurrence. And so there I'm trying to balance continence versus oncologic margins. So many times I don't believe, other than at the apex, that's the one margin you can pretty well control. So in those patients, I'll send a frozen section at the apex right as I begin the radical. So I think that's one margin that you can control. But in general, I think that those are the modifications at the apex and at the nerve bundle as opposed to the nodes.
I'm just going to quickly answer the second question. I think at the moment these patients are offered a chance of cure. So I have no experience, or I have no intention of dropping the dose, because that could compromise the second bite of the cherry. Second thing is that we assume that the modalities of treatment are different. So the first one being cryo or energy devices, and the second one being radiation. There is no way of summing up the damage from the first to the second. So we have no idea how to control for it. If the initial treatment was with radiation, then we have some models where we can calculate, what are the biological equivalent doses that can be used. And I think one of the questions asked yesterday was whether or not there could be a possibility of decreasing the dose to the previously treated areas. For me, perhaps I would consider decreasing the dose to organs at risk if you're worried, particularly if you can see the urethra quite well. So that's something that I think space law is not able to reduce. So I think that's what we have at the moment. Currently, our experience has been full doses after focal therapy. It's well tolerated, good response, until it's been proven otherwise. So that's all I know for now. Thank you very much, Jack.
I was really going to ask a similar question about how you modify radiation in the salvage setting. And the reason I ask is my radiation oncologists, they don't like this whole field. They wish it would go away. And one of the tools that they use to fight is when I send them a patient for radiation, they say, well, we can't give you what we would normally give you. We have to give you a very reduced dose. Dr. Klotz has, put you at risk of failure with this treatment. It's a real issue. So I'm very intrigued to hear that in your view, you really don't have to, is that what you're saying? You really don't, by and large, modify your radiation treatment just because the patients had some previous focal therapy?
Yes, so that's what I do. Whether or not it's just being heroic or it's sheer stupidity, I'm not sure. But I think it's had to do with experience, and I think you're right. So if you don't want to treat a patient, there are many reasons you can give. You know, oh, it's going to be suboptimal. We often say that when the previous high dose of radiation has been given, and then now we're asked to give a second dose, and the context will be if a previous high dose were not able to eradicate the tumor, then this subsequent dose may also have limited chances of doing that. But we have to consider other aspects. So disease-free interval is something that you can use. So it could be a new primary rather than a primary residual or resistant tumor. And number two, I think with the use of genomics, you could stratify these patients better, either using Decipher scoring, which we have here in Singapore, or use of imaging. So we have our radiologist, Dr. Law, is very good at pointing out whether or not these are true recurrences or post-inflammatory changes. With a PSMA PET also. I think one of the things of PSMA PET is sometimes if you're done too close to the original treatment, potentially it could be inflammation or prostatitis. So I have some patients where we give focal boosting, and immediately after the PSA started to rise, and I was a bit worried, but eventually it settled and it was hot on PSMA PET. It was never biopsy, so we can't prove whether it is recurrence, but the idea is that if the PSA comes down, then it cannot be a recurrence. It's probably something that's transient. I don't have a lot of experience, but if you ask me that question in 10 years' time, when I'm closer to the age of your colleagues, I might say the same answer, because actually it's a lot of work trying to do these patients, there's a lot of risks that you're trying to take. And we want to benefit patients by giving them a chance of cure and acceptable toxicities. But my colleague, Michael, may have more to add.
Oh no, look, just following on from Laurie's sort of question, and I agree with you, you can't reduce the dose. Just like Jack has said, he's a surgical oncologist, we are radiation oncologists as well, so you've got to deliver the adequate dose. The only question I have is, I guess it may change the type of radiation that you deliver though. So are you comfortable delivering SABR in these patients? Or would you prefer to use sort of longer course or even moderately hyperfractionated sort of radiation, 16, 20, 78 in 39? Whereas I probably would feel quite uncomfortable delivering SABR in patients who've had focal therapy, especially if it's been close to the urethra.
Yeah, I think that's, well, I tried, the reason why I didn't show any papers because there was a lot of literature on the use of radiation after focal therapy. I mean, taking from first principles, most of us would be more comfortable giving a conventional fractionated treatment. That usually allows us to tailor the doses more easily. We can monitor for acute toxicities and we can stop potentially earlier on. There is some belief that the radiobiology of a SBRT is different. Big fractions are different than conventional fractionated treatment. What we have noticed is that all series of SBRT have shown that toxicity seems to be lower. I think primarily due to the reduction in margins rather than actual dose itself. So what I've done for the few patients I've treated is that I have gone to either conventional or moderate hypofractionated treatment regimens. SBRT is something that is possible. Don't have a lot of experience, but if I were asked to do it, I may reduce the dose. Maybe I 30/5 or 35/5, as opposed to a proper 40/5 dosing in these patients. Or I may want to hedge by giving short course of hormones. But again, that defeats the purpose of minimizing toxicities to patients. Perhaps this would be the topic of study in some patients, but at the moment I don't think we have any data to show this. Radiation have now improved, so we are able to give dose painting. So technically we can actually reduce dose in certain parts that we are concerned about. Especially with an MR linac, which you have, you can actually see it quite well. So I think we are refining our techniques in radiation delivery as well, combination with brachy versus EBRT versus protons. These can all be explored. Yeah.
I do think that one thing we don't talk often enough is that when we plan for primary focal therapy, we look at the MRI 100 times. We look at the biopsy multiple times. You know, we plan all of this. The same principle applies to salvage therapy in this situation. You know, it's a totally different entity if you ablate anteriorly and you have to do, you know, spacer or prostatectomy. Usually it doesn't matter because all you have is periprostatic fat anteriorly of the prostate. However, if you ablated a 60-gram prostate and it's 9 grams now, and you can barely see the, you know, the prostate, even a biopsy in those situations are extremely challenging. I have a few cases where you put an ultrasound probe in there, you can barely see anything. You hope you hit something when you do a biopsy, and you take additional costs because all you need is to prove that they have cancer. You know, in cases like that, I don't think anyone is keen to do a salvage prostatectomy. So I do think that we need to taper our salvage treatment based on what happened initially, you know, as to what we talked about yesterday. That's why I feel like the person doing focal therapy should also, you know, plan on fixing the situation if you didn't render the patient cancer-free. Because if Art, you know, ablates the patient and there's like 10 grams of prostate, I'm not doing his prostatectomy. I send them to Memorial. It's just, you know, it's going to be tough.
Well, maybe last question.
Yeah,
Thank
hi,
you.
Siva from Malaysia. So I've got a question on the effects of hormonal therapy prior to focal therapy. Because I've got patients who were put on hormonal, supposedly thought to be metastatic, but then they came back with lower PSAs, and their initial biopsies were Gleason 4+3. And so now they've come for focal therapy, but my question is, I don't know what's the tumor biology or what's the effect of hormonal therapy onto the prostate gland. Does it reduce vascularity, and would the focal therapy effect then be good enough?
So I guess that, you know, I would never use it to make a candidate who is not a person who's not a candidate for focal by downsizing, right? And I think the concept in radiation is there's a synergy with the radiation, and I don't believe there's evidence to believe that is the case with focal, just as with a radical, right? There's plenty of data from decades ago with the neoadjuvant hormonal therapy, and while it decreased positive margin rates, it really didn't have any impact on biochemical recurrence, unlike in the radiation literature. So I guess if I'm that concerned about the extent of disease and margin, then I wouldn't do focal therapy. I do a radical or radiation.
Well, thank you. It's been an exciting discussion. So for the last talk of the session, I'd like to invite Jack Tay to the stage, the co-chairman of this symposium, to give the closing remark and summary of our symposium on focal therapy and imaging for prostate and kidney disease. Thanks, Jack.
Thanks so much. So we've come to the end of a very exciting segment. I'd like to thank everyone who has come from the day of the masterclass. Yesterday we had a whole day of great sessions, great talks, and great discussion, and excellent discussion and sessions this morning as well. So I just wanted to provide some take-home messages for this segment before we move on to the other segments of Urofair, which are also very exciting, and I encourage you to stay for that. I think that this has been a really interesting melding of the international, regional, and local community. First time FTS meeting has been merged with a national meeting, and first time in Singapore. So I think there were some take-home messages for me. I personally learned so much from all of you, you know, I think I was the great beneficiary of hearing all these talks, and I hope the rest of you were as well. So I think focal therapy adds to the surgical armamentarium for treating prostate cancer, allowing an a la carte and patient-centric. With strong, well, it looks like it's time to go for lunch, but I'll finish this off. Yeah, so I think we have strong data to support focal therapy becoming a mainstream treatment. We've heard all that data. Better patient selection is key. We need to select our patients better. We've been exposed to all the energy modalities, and I think we were really fortunate to have vendors from almost every focal modality being here for that focal therapy masterclass and to expose all the audience to it. I think we're hearing about surveillance protocols, how can we streamline those, looking at longer-term outcomes, and we heard about consensus studies also. And I think we can only achieve success if like-minded individuals are committed to improve oncological care and to understand a patient's desires, not just among the focal therapists, but among the prostatectomists, radiation oncologists, and those managing advanced prostate cancer, our imaging and biopsy, our pathology colleagues as well. So we've heard about how these can come together to really make patient care good. I mean, really, Jeff here is one of my goalkeepers, and that's why I'm so glad that he can give that full dose of radiation even after I've done focal therapy. I think for the Asian community, I think this was the first to have really the region come down, and I think there are so many focal therapists in Asia. I'm very encouraged from Japan, from Thailand, from Malaysia, Taiwan, and China, and I think certainly it's the right time for us to come together and look at Asian data, and the FTS is really a great platform for that. We heard about how the landscape of prostate cancer diagnosis is so heterogeneous in Asia, but how these things are becoming more standardized with more imaging. Definitely we need to work together as a community to look at the Asian data and see how we can support further growth of focal therapy here. For the Singapore community, a special shout out because we could only make our focal therapy program successful because of referrals from the community. And all of you have actually referred patients to our program to support our growing FT program. Really, this is the only reason why we could have this meeting today. So thank all of you. But I think it does highlight the growing evidence that supports focal therapy. It's a bridge between active surveillance and radical treatments, and I do think that it's time, and many of you are interested to learn more and perhaps even get into focal therapy itself. So definitely, I and the FTS are here to support growing a multi-center effort to do more focal therapy. So last, if you felt encouraged and you enjoyed this meeting, join us. This is our website at www.focaltherapy.org. Sign up as a member. You join through the Endourology Society. We have a new website now. All these talks will be on the website for members. So if you want to recap, revisit, please come onto our website. This year, we also have a session on the 15th of August at the WCET, World Congress of Endourology in Seoul, South Korea. And we have our usual US meeting. This time is combined with SIRS, the robotic surgeons. So this will be in September in Washington, D.C. So you are invited to all of these. So thank you again, and enjoy the rest of the meeting. Thank you so much.